Okay, good afternoon everyone. Can I bring us all to attention, if that's okay? We're going to start today's meeting. So good afternoon everyone. My name's Andrew Scotes. I'm a councillor for the Beeson Holbeck ward, and I'm also the chair of the Adults Health and Active Lifestyle Scrutiny Board. I welcome you to today's meeting on the 12th of November. Just to let everybody know, this meeting is a public meeting, so there's people in the public gallery, and also it is being broadcast on YouTube and I think also available on the council's website afterwards. Today's substantive item is really important. We're talking about health inequalities in the city, so I'm really glad that we've got a range of partners to talk about this in a holistic way. So thank you to everyone for coming. I'm going to start by asking board members to introduce themselves, and then we'll come round and ask for the guests to introduce themselves shortly after that. So, as I said, my name is Councillor Andrew Scotes, and I'm the chair of this committee, and we'll go to my left. Thank you.
Thank you, Chair. Good afternoon. My name is Councillor James Gibson. I represent Crossgates and Whitmore Ward.
Good afternoon. Councillor Kevin Ritchie, Bramley and Stanley Ward.
Afternoon, everybody. Councillor Andy Rowntree, Kirkstall Ward.
Good afternoon, Councillor Mahaley Francis for Moortown and Meanwood.
Good afternoon, Councillor Taylor, and I represent Chapel Allerton.
Good afternoon, Councillor Bromley, Horsforth and Rawdon.
Good afternoon, everybody. I'm Jane Mashenko. I'm co-chair of Health Watch Leeds.
Good afternoon, everybody. Councillor Winkage, representing Morley South.
Good afternoon, Councillor Lynn Buckley, representing Old Woodley Ward.
Good afternoon, I'm Councillor Caroline Anderson and I represent Adlon Wharfdale Ward.
Good afternoon, everyone. I'm Angela Brogden, the Principal Scrutiny Advisor.
Super, thank you everyone and welcome again. I'm going to start with the first sort of formal items and pass over to Angela to run us through those. Thank you.
Thank you, Chair. Firstly, under item 1, just to confirm there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. Under item 3, there are no late items. And under item 4, please, at this point, may I ask if board members have any declarations of interests? And I shall take silence as none, thank you. Under item 5, we have received apologies from Councillor Hartbrook. We also have apologies, Chair, from Councillor Venner as Executive Member for Equality, Health and Wellbeing, and from Caroline Barrier as Director of Adults and Health. Thank you.
Thank you very much. Okay, we're going to move on to the minutes next. Firstly, are there any points of accuracy that anyone wants to raise from the minutes? No, okay. So any matters arising, I'll start with Angela, and then if anyone wants to come in, please indicate.
Thank you, Chair. This is in relation to minute 50. Members will be aware that following the board's last meeting and also the executive board meeting that was held on the 16th of October, a letter was subsequently submitted to the Chancellor in relation to the plans for new hospital provision in Leeds. The chair of this scrutiny board was included as one of the signatories to that letter, and so all board members did receive a copy for information. Thank you.
Thank you very much, and I'm sure we'll all enjoy debating that again tomorrow at full council, so I don't suggest we go over it again today, if that's okay. Okay, so on to our substantive item. Just for people who are watching online or watching back, you can, if you put into a search engine Leeds Health Scrutiny Board, you'll come up with the list, and you just click through and you can get the papers we're looking at. But we'll start with introductions. We'll start with Councillor Arif and go round, and then I think, Councillor Arif, if you wanted to say a few introductory words, that'd be great. Thank you.
Hi, afternoon everybody. I'm Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Active Lifestyles and Culture.
Good afternoon. I'm Meg Grassel from Voluntary Action Leeds. I coordinate the Forums and Networks team.
Good afternoon, everyone. Pip from Forum Central, so with the Health and Care Third Sector Network for the City, Pip Goff.
Afternoon, everybody. My name's Magnus Harris and I'm the Chief Medical Officer at Leeds Teaching Hospitals.
Hello, everyone. Victoria Eaton, Director of Public Health at Leeds City Council. Hi, I'm Nick Earle. I'm the Interim Director of Strategy, Planning and Programmes for the ICB in Leeds.
Hi, I'm Tim Fielding. I'm Deputy Director of Public Health here in the Council.
Hello, I'm Sarah Erskine. I'm Head of Public Health for Health Inequalities.
Hi, my name's Anna Ray. I'm a consultant in public health who works across 3 of the kind of NHS trusts in Leeds, so the Community Trust, the Mental Health Trust and the Acute Trust.
Afternoon everyone, I'm Kash Ahmed, Deputy Director for Integrated Commissioning, Adults on Health.
Good afternoon everyone, I'm Shona McFarlane, Deputy Director, Social Work and Social Care Services for Adults and Health. Thank you.
Thank you, Chair. So this doesn't fall in my portfolio anymore, but I was the Executive Member for Public Health. Councillor Venner is really sorry she's not able to be here. I know she's extremely passionate about health inequalities. When I took on the public health portfolio at the time, we were going through the COVID pandemic, and what became extremely evident at that moment in time was health inequalities going in the wrong direction. And I think at that moment in time, it was very much important for us as a council, particularly in public health, to deal with what we were dealing with, but also having an eye in the future in terms of what could we do in terms of looking at health inequalities, which are telling us they're going every direction, every indicator was going in the wrong direction. A few years later, we had what I would also say a pandemic, which was the cost of living crisis, in my view, which has further exacerbated health inequalities. In terms of a response from a public health perspective, I was at the very beginning of that journey of becoming a marmot city, which I think was, again, Leeds City Council showing their commitment to wanting to deal with health inequalities. And I know over the last couple of years, a lot of really, really good and important work has happened, in particular when it comes to our younger children Best Start. We've looked at some really important work in terms of housing. The report itself is a really, really important report. It really does, unfortunately, it doesn't paint the best of picture in terms of where we are, but the commitment is very much there from us as a council, but also the third sector and the very important role the third sector plays within this really important agenda. I'm really looking forward to the debate. As somebody who represents Gipton Hare Hills, where we have got one of the worst health inequalities in the area, it's something I'm extremely passionate about. So I look forward to how the debate goes. I'm just really, really pleased that this is a conversation we are having at scrutiny, because it's an extremely relevant conversation, and I very much look forward to hearing from colleagues, but also from members on the board for their input as well. Thank you.
Victoria, do you want to come in? I think you've got some slides.
Thank you, Chair. Yes, I'll follow on from Councillor Arif and just give some opening comments to the presentation, which will be delivered by partners across the system. Just a few opening comments. I think the first one, to echo what Councillor Arif has just said, is I really thank you as a board for the opportunity to bring this to a dedicated workshop today. I echo what Councillor Arif said around the importance of this agenda for the city. So the conversation here today is incredibly welcome, so thank you. From the papers that you've got in your packs, clearly you'll see that the agenda is very complex. The causes of health inequalities are very complex, and therefore the action to address them across the city is complex. And there are many partners involved. So the papers that you've got won't do justice to all the work we do across the city, but what they have done is tried to set out our major approaches strategically for how we are working to address health inequalities across our city. And partners here around the table are very much part of that. I did want to say that even though there are 2 separate papers, one of which is mainly focused on the role of public health and the council, and the other one which is mainly focused on the contribution of the NHS and care system. We stress at the beginning of the conversation that we don't work in a separate way. around those two silos of work, that the way in which we work around health inequalities is absolutely across the system as part of the day job. Day in, day out, I would work with these colleagues around the table and many others in addressing health inequalities. So the papers are written to ask the questions that the board has presented, which were particularly to look at the roles of the health and care system and public health, but the approach is absolutely integrated. There's always much more we can do around that, but I wanted to stress that. And then finally, again, to echo Councillor Arif's opening comments, I'm sure that board members will know that we have had a long-standing commitment as a city to addressing health inequalities, but we still face major challenges, and hopefully the paper and the presentation sets that out clearly around the nature of the challenges we face and how we're responding to those. There is lots of pressure in the current system, not least with our financial challenge across both local government and the NHS, and how we continue to develop the approach and commitment to health inequalities at a time of financial challenge where decisions are made about resources every day, and how we mitigate the impact of those around the work around health inequalities. So that will be covered as part of the presentation, but it felt an important point to say at the beginning that we are working in incredibly challenging financial times. And then finally, just to assure the board that all the work that we talk about in the presentation and in the papers is all based on the best available evidence that we have, and also a strong commitment to partnership working. Councillor Arif talked about after COVID, where for most people health inequalities were the most visible they've ever been in people's lifetimes. As a city, we committed to go further through becoming a marmot place, and we'll cover what that work has meant to our response around inequalities. We are mid-programme as well in our Marmot City work, so it's very live, and we really welcome the comments and discussion here from Scrutiny Board about how we continue to take that work forward after today. So I shall leave it there. Thank you, Chair, and hand on to my colleague Magnus.
Thanks, Victoria. Chair, board members, really excited to be here, actually. So as the largest health and care provider in the city and one of the biggest in the country, it's quite a unique position for me to be here representing LTHT. Our board are fully behind the collaborative working that Victoria's described. The tricky bit for me is working out how we, as a statutory organisation with all that entails, start focusing our consultants to look beyond the walls of LTHT, to start focusing our other staff to look beyond the walls of LTHT. And that's actually quite tricky when we've got regulatory environment and statutory targets to meet, because it can actually, they can pull against each other. There's polarities there. But it's huge, complex, collaborative work that's absolutely appropriate and really important. And I think with the NHS 10-year plan and the 3 shifts that we know about and the shifts we're expecting to see, we have to ask ourselves at LTHT what our role is in this. Very happy to be here. Happy to work with colleagues in this space, and I'll leave it at that. Thank you, Chair.
Thanks, Chair, and thanks, Magnus and Victoria. I'm just going to try and run through a few slides now, just to try and give a bit of an overview and context, hopefully, particularly pick up on some of the public health aspects. So in terms of what we're hoping to cover in the brief presentation, there on the slide in front of you, really at the bottom, just wanting to really emphasise, I guess, as we go into this, as others have said, the whole issue of health inequalities is a hugely complex area and very hard to sometimes separate just from what is core business or from anything else. So actually, as we'll see when we go through, separating out the work we do on health inequalities as opposed to the work we do on anything else is almost impossible. And therefore, I guess by definition, we're not going to be able to fully capture everything by any means that's done across even ourselves, never mind other colleagues and partners on this area. and it really is expansive. Thanks. Okay, if you carry on to the next one, thanks. The first thing is really, I suppose, just emphasising what it is that we're ultimately talking about and what it is that we're trying to achieve. And we talk a lot about health inequalities and about addressing health inequalities. I think there are some key points that are worth emphasising. The fact they are systematic, they are not just down to individual behaviours, they are about systematic, unfair and avoidable differences in a large amount of cases between those different groups. And ultimately, we're trying to address those inequalities and reduce them with an aspiration about improving and achieving a greater point of health equity. And it is that principle that some people will need different levels of support or provision within that, and it's that sense of proportional support for people to achieve that health equity. Thank you. The next thing I just wanted to emphasise, I suppose, is about the breadth and scope when we're talking about health inequalities. One of the areas we concentrate most heavily on is around inequalities based on deprivation. So we talk a lot about IMD, the index of multiple deprivation, and much of the content in other slides here will be based on that. And that's hugely significant. And we do see a social gradient almost through just about every risk factor for health and just about every outcome of health outcome in terms of a social gradient, where the more deprived you are, or the more deprived areas you live, on average, the worse your health outcomes are than higher up. But what's important is that applies all the way up that gradient. It isn't just a case of the most and the least. It works all the way up. However, there are a range of other factors that can also cause inequalities, which are very much part of this. So that can be around particular vulnerable groups, or what are sometimes classed as inclusion health groups. It can be around protected characteristics. One example, for example, that we know and certainly got a lot of prominence through COVID was around ethnicity, that operates as a cause of health inequalities in and of itself, as well as linked to deprivation and geography. But critically, it's that intersectionality between all of them that really applies, and many people that do suffer those inequalities are impacted by a whole range of some of those the factors that contribute to that. Thanks. We also talk a lot about when we talk about health and when we talk about health inequalities, often the default is to think about health services and access to health services, access to GPs, access to hospital services. But what's really critical is understanding and that appreciation that actually the vast majority of what makes us healthy, and therefore also what causes health inequalities, isn't actually directly to do with health. And the approximate estimate is that up to about a fifth of what makes us healthy or causes those inequalities is to do with health services, and the rest is to do with all of the wider range of wider determinants and social determinants. So as we can see, those issues around where people, the conditions people are born into, grow up in, live in, their housing, their access to food, their economic status, employment status, etc. Thank you. So this is a slide that we really wanted to put in and just tries to bring that together and really emphasise ultimately what we're talking about in many cases. Now, this is a national slide, but it absolutely applies, and the same data applies in Leeds. And the top line refers to people that are the most deprived, so effectively within the most deprived 10% of neighbourhoods in the country. And the bottom line is the least deprived 10% in the country. And what you can see, this is about healthy life expectancy. So the end far right of it is ultimately the healthy life, is life expectancy, and the blue line is the healthy life expectancy. What it shows is that for those that are more deprived, they spend a considerable, firstly, their life is shorter overall. Secondly, they spend a considerably shorter period of their life in good health, and a far higher greater time and proportion of their life in poor health. And I think if you see where the line of the retirement line is, you can see that there's about a 20-year difference between those most deprived and least deprived in terms of when they're hitting that state of poor health. And actually, for those that are most deprived, they're hitting states of poor health on average just in their early 50s, considerably below that retirement age. Huge amount of that is avoidable, is simply unfair, and much of the work is about reducing as I say, that gap. Thanks. So just to put that in some context for Leeds in terms of what we're all collectively working on and trying to address, this is just an illustration of the inequalities that exist in Leeds, and this is, as I say, just one illustration. This is an illustration by a 10-mile bus route running from Hunslet through to Harewood, illustrating the approximately 12-year difference in life expectancy that can be seen throughout that journey, just indicating that gradient that we have that runs right the way through, and we can see that between many other areas. And if we look at the next slide, thanks Angela, you can see the distribution. People, I'm sure, in this room will be very familiar with that distribution. Those areas in red are the areas that fall within the most 10% deprived in the country, and I think this is really important. It isn't the 10% of Leeds most deprived versus the 10% least. So if all the neighbourhoods in the country are broken up into deciles, the ones in red fall into the most deprived in the country. Now in Leeds that accounts for nearly a quarter of the population, and the ones in blue are the ones that are the least deprived. What I think is also really important to mention about this is that we're seeing that demographic change as well. So we are seeing the proportion that are living in the most deprived increasing year on year. And so we're seeing the greatest birth rates, we're seeing the greatest levels of ethnicity and diversity, and we're seeing the greatest increase in those areas of deprivation, all of which obviously is a demographic challenge to us in terms of our inequalities. And just to show that a slightly different way, if that's okay, Angela, thanks. So this is, as I was saying, this is basically children's population on the left, adult population on the right. And if we were the same levels of economic inequality and deprivation as the national level, we would expect a tenth of our child and adult population to be living in areas classed as the 10% most deprived. In actual fact, what we see in Leeds, if we go on to the next slide, is it accounts for a third of our children in Leeds live in areas among the most deprived 10% of the country, and a quarter of our adults, which I think just gives a real illustration of quite the challenge that we're facing and some of the underlying inequality that we face. And obviously to be in the most deprived 10% in the country is quite significant. Okay, so just very briefly before we go on, we have a really, emphasising the points that were made earlier, we have an extremely strategic approach, I think, to across the city that's joined up. People will be very familiar with the Best City Ambition, which is our inequality and poverty strategy for the city, with a real focus there on improving the health of the poorest the fastest, and 3 pillars that sit underneath that. The 2, I guess, most critically relevant to this are the health and wellbeing strategy and the inclusive growth strategy, both of which have a really strong emphasis and we work incredibly closely with. And the Healthy Leeds plan, which is the health and care partnership response to the health and wellbeing strategy, which we'll talk about more in a second. Thank you. In public health, I'm not going to try and reiterate all the content that's in the first of the appendices in the paper, which describes, hopefully in some detail, some of the ways we tackle inequalities in public health. But you can see the way we structure ourselves in public health on the left in terms of the work programmes. And it's absolutely throughout, at the very heart of the work we do on public health, is addressing inequalities. The way in which we do that through being data-driven and needs-based in the way we work, through the nature of the needs assessments that we take and undertake to try and identify those needs, having that proportional, universalist or targeted approach through the services that we commission, KPIs and focused on inequalities, the way we report performance, critically including to scrutiny here twice yearly, where we do that broken down by inequalities, and some of that wider system leadership and the community-based approaches too. But as I mentioned, actually it isn't just about the work we do in public health by any stretch of imagination, and actually all of those wider determinants mean that it is the entire system that's critical. So, as was mentioned at the beginning, not only colleagues across the council, but critically around the third sector, around education sectors, and also around business, and a huge amount of examples, hopefully, that you can see in the paper about the way in which we work with planning, housing, transport colleagues, and regeneration, as well as inclusive growth. If you can just flick a couple of slides ahead. Sorry, Angela, for some reason they ended up slightly out of order. One more. And really, just as a segue in my final slide, it's already been mentioned about the fact that we've been a marmot city, and it was that recognition of the importance of those social determinants that was a driver for becoming a marmot city. The work that's happened, and Councillor Arif has already mentioned the report that's been published. This is the front page of the report. If people haven't seen it, hopefully people will have. And on the right there is the list of documents that are available on the Institute of Health Equity website, showing quite the sheer amount of work that's happened through the Marmot City work, including those overarching recommendations, but also the detail around the housing work that's been done, the 0 to 5 work that's been done, and the work around developing the indicator set as a way of monitoring inequalities going forward. And the Health and Housing group has taken forward the health and housing work, and that's going to the exec board this month, I believe. And we just had a joint health and wellbeing board and Children and Young People's Partnership workshop taking forward the 0 to 5 recommendations, which are going to be owned by the Best Start and Beyond group going forward. So really fantastic progress around that. So if I'll finish there, and if we can just flick back a couple of slides, please, Angela, and I'll hand over to Pip. One more. Thanks.
Thank you so much. Yeah, we just wanted to talk a little bit, the next slide on actually, around the contribution of the third sector. You know, as many of you will know, the third sector makes a really significant contribution around health inequalities through the investment that it gets from public health and Leeds City Council and the NHS. But also from the resource that it's able to lever into the city from lots of other places. So we know that the third sector has around £325 million that it's investing in our people and our communities. And this slide is taken from our State of the Sector report, which hopefully people have seen, and which helps us to sort of describe the breadth and reach of our really diverse and comprehensive third sector that we have in Leeds. Although we have seen a reduction in the number of organisations, particularly emerging micro and small organisations, has significantly fallen. We've also lost 34% of people employed in the third sector and 25% of volunteers over the last 4 years. So we have concerns about kind of future sustainability and viability. The next slide says a little bit about some of the ways in which we're working collaboratively. The brilliant work that Meg has done on behalf of Third Sector Leeds has described our ambition as Leeds as being a city where all partners work together to ensure that the third sector is diverse, resilient, and therefore best able to support our communities. So some of the ways that we've been able to use this kind of very helpful strategy work, we've taken it through with Nick and colleagues at the ICB to develop a position statement, really positive ambition and aspiration. We know that we've got lots of different ways in which the third sector is demonstrating activity. You'll know Salma, Councillor Arif touched on the in COVID when the community anchor network in all of the different wards and communities across the city really rose to the challenge. We've got fantastic provision like Enhance and Forward Leads. We've got some fantastic collaboration and partnership ways in which the third sector works across different organisations and with statutory partners. And we've got huge provision of examples across young people, mental health, learning disabilities and employment. We've got so many really great examples of the work. And finally, I just wanted to touch on some of the workforce work that we've done across the system. So with the Health and Care Academy, which has actually been one of the ways in which third sector resilience has been supported through these difficult challenges by sharing training and information and well-being across our workforce, recognising that people from our most diverse and challenged communities can have a really positive journey into employment and out of poverty. For example, loads more to say really. The final slide we just wanted to touch on how, as a third sector, we're trying to make sure that the work we do is really strongly knitted in across our city's strategies and ambitions. I think social value gives us a huge opportunity to think how we can work differently, and health inequalities is absolutely one of the ways where we can see those benefit through marginalised communities. Our mantra around being bold and scaling up and investing through the Healthy Leeds Plan 2 that's in the document present huge opportunities to really innovate and invest in our communities, to trust people across our city to be part of the solution. And we know from the King's Fund and some of the national intention around integrated communities that we do have a real opportunity if we can seize and be bold around that. We do worry about some of what we've lost, and we have been raising concerns both in the sort of Leeds City Council corporate risk and at West Yorkshire, and I won't say any more about that, but the risk there that's highlighted at the bottom of this slide from West Yorkshire ICB about the risk of loss of third sector having even greater impact on health inequalities, I think is something that we need to really bear in mind in our next discussion.
Thanks, Pip. If we could just skip through a couple of slides, that would be fab. One more. Perfect. So I think, as Tim has emphasised several times, health and care often are kind of what we think about when we think about our health. But actually, just to emphasise, we know it is only a kind of a small contribution to what makes us healthy. But I'm going to touch on it because it's small, but it is quite a complex and important contribution to what makes us healthy as well. So next slide, please. Now, in my role, I'm often kind of NHS facing and often talking to kind of NHS colleagues and getting them to do something around health inequalities. So I find it quite helpful to refer to this diagram where we can see, yes, health and social care just make up kind of that 20% of what makes us healthy. But I also encourage colleagues in the NHS to kind of think through how could we lean into some of these other areas a little bit more as well. So, for example, things around health behaviours. We have a role potentially in the NHS through kind of preventative programmes to kind of lean into that aspect of health a little bit more. And those other factors like the environment, social economic factors, you know, the NHS is an enormous organisation, big institution, and there's many roles that they can kind of play either through influence or through other things about their role as an anchor institution and making sure that they are thinking about those broader determinants of health as well. So within health and care, we're really accepting that there's many risk factors, many things that impact health inequalities and health that are beyond our control, but really there it's about kind of pushing organisations to think about how can they maximise their contribution to reducing inequality. Next slide, thank you. So just to kind of highlight kind of some of the strategic context within health and care. So the Healthy Leeds plan is really the health and care contribution to delivering that overall health and wellbeing strategy for the city. It's not about kind of putting everything in that plan, everything that every organisation does, but it's about saying, what are we going to do together in partnership to improve health? So there's a couple of goals there, and those goals were determined through really examining what are the health needs of our most kind of deprived population. So there it's kind of written as IMD1, but our most deprived populations, that's how those goals were determined. And you'll see there from the goals, one is about reducing preventable unplanned care. The second one is about increasing early identification and interventions. Now they sound fairly kind of separate. One's about unplanned care, one's about kind of prevention and things, but actually we know that unplanned care is really kind of high in our most deprived populations because we're not necessarily meeting their health needs through planned care and through identifying diseases early, through providing that correct management and intervention. So then they kind of end up in that kind of A&E, that acute setting. So those two goals are quite kind of interrelated as well, even though they might seem a little bit separate at first glance. Next slide, please. So underneath the Healthy Leeds plan, there's several organisations within the kind of Leeds health and care system. Just highlighting here kind of some of the approach from NHS providers. So the different organisations, the Community Trust, the Acute Trust, the Mental Health Trust, also kind of have their own strategies for tackling health inequalities that kind of sit under the Healthy Leeds plan. So the way we encourage the organisations to think about their role there, about tackling inequalities, is really to say, as a healthcare provider, what can you do? As a partner in the system, what influence can you have? And also as an anchor institution, what can you lean into? So those wider determinants pieces there. So on the bottom of the slide there are just a couple of extracts from two of the trust strategies that sit under there. Basically recognising that ultimately we want to provide equitable clinical services, we want to provide those really proactive preventative programmes to prevent ill health in the future, but recognising there's probably quite a lot of work that needs to be done before they kind of get to those deliverables. That actually there's lots of foundational pieces around data, around better engagement with patients and communities, leadership, etc., that needs to be built before we can expect, our services to become kind of equitable. So I'm just going to pass to my colleague Nick to summarise. Thanks.
Thank you. And I think this is the last slide. So I guess just wanted to end on a few reflections around opportunities and challenges here. I'd start by noting that the report provided gives a really huge overview of the work underway on health inequalities across the partnership. So thank you both Chair and Board for having us here to focus on that. And also thank you to colleagues. It's really nice to have such a wide set of colleagues all speaking from the same point of view when they come to talk about this. I'm not from Leeds, you may be able to tell from my accent, but actually it's this work that I think sets Leeds apart. And there's few cities where we'd see such a collective commitment to health inequalities with that strong focus in all of the plans that you've heard described today. You'll notice in a few areas that the focus is obviously on deprivation. That's clearly where we feel we can make the most impact and where the most important focus should be. But the paper spans much more than that and summarises that work across the public health programmes, across health and care partners, and actually organisations dotted around the city. There is a set of work ongoing around our foundations and the enabling components. So have we got the right data? Have we got the right partnerships? Have we got the right connections to communities? And each organisation will have a role to play in that. But collectively, the focus is there of doing it together, which is the important part. Important to acknowledge that the funding challenges have made this difficult. One of the things that we're doing is working through that in partnership and as a partnership and taking that collective focus on mitigating the impact that those funding changes have on our most deprived populations. And I guess that's the sort of key and the title of the Mohammed City report about maintaining that emphasis on Leeds as a healthy and fairer city. That's it from me, but just ending on a thank you to all the colleagues that have helped present and bring that to life.
Good, thank you very much. I appreciate that. That's very interesting. I'm going to ask a couple of questions, and then as they're answering, please indicate if you want to come in. So I guess the two questions. So the first one was around a quarter of the people in Leeds live in the bottom decile. And from what you said, Tim, it sounds like that's an increasing proportion of our city, which is clearly very concerning. What I'd be interested to know is, have you seen any changes in trade started? What else needs to be done to change that trend? And the other question I have is, have we done any work around the overall changes in services or cuts to services over the last period of time, and done any sort of like cumulative impact assessment, and whether that's helping or not helping? Thank you.
Do you want me to take the first part of that, and then, yeah, if other colleagues might want to come in around some of the other service areas? Yes, just to say the proportion in those most deprived areas is increasing, and obviously that's a quite complex sort of range of reasons why. Some of that will be about higher birth rates in some of those areas. Some of that will be about inward migration into the city as well. Have we seen any change in that? We certainly haven't seen any change in that specifically in the 18 months or so since we've been doing the Marmot City work. I think the real areas and opportunities around trying to address those really underlying issues around poverty and deprivation that drive some of that inequality is recognising the range of levers, I guess, that sit available to us. And the most obvious one of those in that respect is actually about the inclusive growth strategy, and really focusing on the breadth of people's economic ability. So it's focusing, and also I guess on wider education. So that's where we are doing quite a lot of work in that, and the relationships we've built up with the inclusive growth and regeneration colleagues, certainly for ourselves in public health, have come on a huge amount in the last 18 months. They've been very closely involved. Both myself and Sarah spend a lot of time working with those inclusive growth colleagues, and there's some really good examples I think there, and their engagement in that Marmot City work has been really positive. So none of that, I'm not under any illusion how challenging that's going to be to turn around and to try and address that. But I think having a really clear line of sight on that is going to be absolutely critical. And one of the things that we are I suppose trying to embed throughout is having that line of sight around those inequalities. So when we look at indicators, whatever it is, whether they're economic indicators, whether they're employment indicators, whether they're educational indicators, or whether they're health indicators, that we aren't just looking at them as an average for the city, because if we do, we miss the significance of those inequalities for that quarter, but that we do break them down and disaggregate those by IMD and by other factors. So we do have that clear line of sight. We are able to understand that picture, and we are able to monitor and see, and hopefully see that improvement over time. And that's something where we are getting really good purchase with lots of colleagues right across the system in doing that. I'm sorry, I don't know if other colleagues want to come in and talk more about that, the assessment. I can say a bit about it.
Just going to add briefly on the cumulative impact. So one, there's a technical challenge in doing it in detail across just given the number of organisations and services involved. One of the things we do as a partnership is share what our plans are and challenge each other about whether they are impacting the same populations. That shouldn't be overlooked as a way to mitigate. Actually, that's interesting. They all land in one area or in one population, and that often becomes apparent through that process. The other thing that we do is we take a consistent set of impact assessments against the key criteria in the Equality Act when we review decisions independently as organisations. And certainly in the ICB, one of the things that we do is we look at those within our populations. So we segment the population into 9 different segments. You'll recognise most of them, but they are things like healthy, children, those with long-term conditions. And then we're able to look by placing those impact assessments for all the services that affect those people, what is the sum total of changes we're making, so that we can consider that cumulative impact. So I think the answer is yes, we do in organisations in terms of looking at the cumulative impact. As a partnership, what we do is discuss it and share those plans to mitigate the risk. But there isn't a single technical analysis that covers all of those across all organisations and services. but colleagues may want to add to that or comment further.
Okay, it doesn't look like anyone's indicating, but thank you. That's really helpful, both those comments. Okay, I'm going to bring in Councillor Gibson and other colleagues. If you want to indicate, please do.
Thank you, Chair. And thank you for this fantastic report. You know, it's tackling health inequalities has come to this committee a lot, and you know, every time you do present what you've been doing, I'm always incredibly impressed. And I think we do stand out as a city, and for the way that we're firstly recognise health inequalities, but for the way that we're trying to work collaboratively and holistically to try and tackle them. And I've always taken a lot of pride and pleasure in talking to other councillors from other areas about what we're able to do here in this city. But there has been a change, I think, since the new government, and I think it was specifically in the manifesto of the new government to talk about tackling health inequalities. I think the quote, I think the aim was halving the gap on healthy life expectancy between the richest and poorest regions. There was also a lot of talk in the build-up over the past few months as well. Sorry, few months, sort of the start of the year. You know, you heard our now Health Secretary Wes Streeting talking about Marmot as well. So it feels like this now is on a sort of national level. It's on the agenda finally, and I wondered how that is filtering down to us as a city. Is the government reaching out to learn the lessons from what we've been doing? Are they providing more support? Just wondering if there has been a change yet. I know it's early days.
Yeah, so just a couple of points from me, and again, I think this is probably one that everybody will have a few bits that they can speak to on that. So I've been contacted recently by NHS England asking precisely these questions. How are you approaching it in partnership? I'm also aware that there's a DHSC, there's a health and social care hub in the city, which is specifically designed to connect national policy questions to local delivery. And these are exactly the sort of questions that they dig into. And I guess, thirdly, I think just on the broader impact, actually Leeds has felt like it's been one step ahead in this area in particular. So the second goal of the Healthy Leeds plan, the priorities within that were identified precisely by examining the gap between the most deprived and the least deprived in terms of impact on life expectancy. And I don't think, you know, it's really great to see some of those leaders coming from Leeds, moving to national government, actually helping the narrative more broadly. So whereas before we might have struggled to get traction in certain actions, now what we're seeing is the national voice supporting exactly in line with what we'd aim to do. So I haven't fully seen that land entirely in Leeds, but it's really helpful to see that now everything that we're saying is being reflected nationally, and that's really helped move some of the discussions along.
Thanks, Chair. Can I jump in there? Thank you, Councillor Scopes. So thank you, Councillor Gibson, for your comments. We'll, that's really great to hear, and we'll feed that back to the team. In terms of being approached by new government, as you can imagine, there are lots of conversations happening around, you know, what's working well, how we scale that up, for example. And I think, you know, I think we can say that Leeds is quite well represented in those conversations because we've done a lot around health inequalities. We know we need to do more, which is the kind of ultimate purpose of the Marmot work, really, in terms of how we scale up and meet the challenge, building on what's already in place. So there's a lot of great work that's already happening in the city. I mean, one example, Tim didn't get a chance to bring it out, but it's in the paper, hopefully, that every single one of our council commissioned public health frontline services, every single one of them has got a sort of proportionate targeted approach in terms of the people we need to meet the most. We don't do kind of blanket services. We tailor and target all of our services based on the needs of the population, and that's not something that many places do. So, you know, there are great examples of things we do here which we just take as standard practice around inequality that are not universal. But I would say, in answer to your question, that we are needing to be quite proactive in engaging with government colleagues and ministers around things that we want to get in their attention. I think we've got a really good relationship with Chief Medical Officer who's visited us several times recently, who recognises some of the great work that we do, particularly in communities. We took him up to Harehill last time, Councillor Arif, didn't we? And his feedback was that it completely changed his thinking around how to work with communities in a very positive way. So there are lots of examples of that. But having said that, we know that even with all this great work, things are still challenging. And Tim talked briefly about our performance report that we bring here anyway, and being really clear about the narrative around health inequalities. So there are some things that are either staying the same or moving in a slightly more positive direction, and we need to, you know, so for example, avoidable preventable deaths under 75, some of our drug and alcohol related admissions to hospital, etc., are going in a positive direction. So it's not all a kind of a blanket picture across every single indicator, but we know that some of them are a worry and going in the opposite direction. And for most of our measures, we've got this completely stubborn gap between the two bars that Tim showed on his slide before. So I think that stubbornness and the push of the Marmot work to really scale up, be bold and join up is where I think we would all agree we need to be, because, you know, this is a major structural issue in a major British city. We're not going to solve this with a couple of new projects. It always has to be systematic, working at scale. I just wanted to share in terms of us being proactive with the work we already do. We're absolutely doing that, but we know we need to do more as a city because of all the things that have been described in the presentation, that demographic change. Thank you.
Thank you. Meg, do you want to come in next?
Thank you. Yeah, I suppose just to add on from like a third sector perspective, I think, and in answer to your question, Councillor, I think we've seen some really, over the past couple of years, there have been lots of reports about the importance of working with the third sector, the impact that has on communities and on public health. But just recently, I suppose what was really encouraging was the Prime Minister and Lisa Nandy have announced their intention to launch a civil society covenant in sort of recognition that some of the challenges that we face are not ones that just central government or local government can address. Actually, they need a much wider kind of partnership approach. And so within the third sector, we are kind of responding to that consultation, and I think we're really fortunate that we already have some really strong partnership working relationships. We have things like the third sector strategy and lots of examples of good partnership working. But I think it's really encouraging to see that kind of acknowledgement that actually, as colleagues have said, health services are a really small proportion of people being healthy, and it is a wider kind of community and partnership effort.
Thank you. Pip, did you want to come in next?
Thank you so much. Yes, I mean, absolutely. I think Leeds is in a really good position. We're a kind of bit of a microcosm for all of the issues, and we're also, you know, seen as we've heard as a kind of well-functioning bit of the system where we have got really good relationships and good assets and things that we can work on. But we also, I think, need to acknowledge it is an enormous challenge and a huge shift to be bold and different. you know, I've just come off a West Yorkshire call this morning talking about some of the preparation for winter, and we know, don't we, that there's a lot of kind of targets that are around the hospital and around beds and some of those sort of NHS targets, you know, which are obviously really important, and, you know, they make big news, don't they? People are very interested in knowing what's happening. Absolutely rightly so, because we want the best possible service that we can have from our NHS and when we do need to be in hospital. But we also, if we're really going to make some of that shift into prevention, are going to have some different and very difficult decisions. We have a finite amount of resource, and we are going to have to really make some difficult decisions that involve some of that shift. If anything, we've probably done a bit of a shift to spending more actually in sort of more traditional approaches, whereas actually it's brilliant that we're all aiming to have prevention and to invest in communities, but it takes a longer view and it won't be easy. It will involve things, the King's Fund, as I think I mentioned earlier, have got some really good approaches laid out around the opportunities in the 10-year plan, and they've got 7 kind of key areas that they think that, you know, we can do. We've got sort of good national learning from other places that we can use. And it includes things like tackling racism and discrimination and training our whole workforce to understand what working differently around health inequalities would mean. And it also does mean making sure that we're sort of investing in that shift in culture. And Health Watch have done some brilliant work locally around the 3 C's around compassion and making sure that we're joined up and that we care. We've got to kind of really think about what it means at every level of what we're doing. So I think there's a lot that we do know and that we know that we can do, but it won't be easy, and we will have to be bold and we will have to work together. I also just, if I could very briefly want to mention...
Sorry, Pip, just, I'm not quite sure how this is answering the question about whether the government's...
I suppose my point is the government has some very clear and bold intentions around prevention, but it also has other things which can often seem at odds with what we're trying to do in terms of prevention and invest into communities and different ways of working, whilst there are also huge pressures, you know, rightly so, to, you know, meet some of those NHS targets. So it's how do we make sure that we're balancing those different they're different pressures, aren't they, that we get there. Sorry, so I was just trying to make sure that we recognise that it will require us to be bold and stand together on some of those firm commitments. Can I also just really, really briefly mention ageing population, because one of the other things we know is around people who will have years in areas of deprivation of poor health, and I think that's a massive issue that we also mustn't lose sight of.
Yeah, thank you. Just so you know, we did have the Asian Well at our last meeting. Thank you. Magnus, do you want to come in next? Pip, can you just turn your microphone off? Thank you.
Thank you, Chair. I think to summarise, we seem to have a ministerial visit at LTHT almost every week. Karen Smythe, one of the Ministers of State for Health, was with us yesterday. West Streeting and Sir Keir Starmer were here before they were in government. West Streeting's been again. The Chancellor of the Exchequer was at one of our lung health screening sessions in Pudsey. The way we work, the Leeds Improvement Method and the Leeds Way values are well recognised nationally, and there's a large focus on how we can replicate throughout the country. So I think the answer to the question from an acute provider perspective, yes, we get lots of visits.
Thank you. I think that exactly answers the question. Do you have a supplementary, Councillor Gibson? No, thank you. Super, thanks for that. Okay, Jane, you're next. Thank you.
Thank you, Chair. I have a few questions. This is my area of significant interest, personally, and Health Watches. So my first question, and forgive me if this is all in hand, but this is such a crucial conversation, and as you say, it goes much beyond health and care services. I think absolutely for that 20%, if we don't get it right, then that amplifies and really makes health inequality is even more problematic, but we also need to be mindful of the other 80%. So I suppose my question is, the Marmot report is fantastic, so if anybody hasn't read it, then please read it. And the recommendations are crucial. How do we get every key stakeholder signing up to those, really? So beyond the people around this table. Are you going to all scrutiny boards? Are you engaging with the business sector, for example? Are they going to be making decisions and reviewing their policies with a Marmot lens? I suppose that's kind of fundamental to really drive the cultural change in the city. That's one. Do you want me to stop there?
No, if you ask your questions, and then we'll come back.
My next question is much more specific, and it was just a kind of recognition. It's in the report, page 46, about the complexity that we, the government, have created in terms of our local communities' geographical boundaries of different partners. So we have school clusters, we have ward boundaries, we have the kind of community footprints, we have the local care partnerships for primary care, and they don't match. And that really makes it problematic when you're trying to do a specific piece, and it doesn't make any sense. People that live in those communities don't think about those boundaries. So, and it's kind of recognised within the report, and it's just, is that really going to be seized hold of finally and taken forward? Are we going to get something sorted? Because it's so messy, isn't it, when you're trying to work together in your slightly different boundaries. So that's my second question. Sorry. My third one is specifically relating to the health and care partnership element of the report, and it's talking about the priorities and about the first one in particular around kind of presenting in crisis. And I just wanted to express a bit of disappointment that it's focused on physical presentation and admission to hospital. When we know, we've been talking about the impact of the pandemic and the economic situation and how that has driven need for mental health up, and how there's more demand for crisis services in mental health, both for adults and children and young people in particular. So I was just a little bit disappointed that there wasn't an equal strength of focus in that, given we know there is also lack of parity of investment around mental health. And then finally, it's really good to know, and I think it's quite a new process the ICB have initiated in terms of their looking at their financial cutting and equality and impact of those, and the kind of equity impact of those decisions. And I know they're taking that process through the committee, etc. And I know that they're going to be building and improving that process and being even more proactive. I know the council have been doing this for some time. My concern, and it's not just mine, it's Health Watch's concern, is that there's a lot of this happening within organisations as well. So the provider organisations are undertaking their own process, so LCH, LTHT, LYPFT, the ICB does theirs, the council do theirs. I don't think there's enough transparent sharing and mitigation of where it's likely to hit the same vulnerable groups. So that's one aspect of that. The other I wanted to flag is that there are some things that are not cuts as in removal of a service, but are tightening of resources. So I can give a specific example. So one of the things we do at Health Watch is we follow individuals to share their experiences of trying to access services in the city. And there was one woman who very kindly shared her experience, and she was somebody that lives in Chapeltown and is registered blind, and so that needs various services. She, I have to say, was waxing lyrical about the support she got from the third sector, so just to recognise that. But not so waxing quite so lyrical about some of the experience of the statutory sector. One particular thing that struck home was that she had been getting help for getting her, from podiatry, LCH podiatry. She'd be getting her toenails looked after. But then she didn't fit the criteria. They hadn't changed the criteria, but they'd seen she was somebody who had few family, who was registered blind, who couldn't manage to do it herself. And so they had been doing this for her. But then they suddenly started delivering to policy. And that flexibility had gone. And I think sometimes we forget that aspect that can have a significant impact on the people who all the cuts hit the most, let's be honest. Okay.
So I think I'll answer the first one. Thank you, Jane, for those multiple questions. In terms of the Marmot City recommendations, the whole system recommendations, we have a multi-agency partnership group called the Marmot Strategic Delivery Partnership that has representation from the Leeds for Inclusive Growth and Economic Development Asset Management region. We have a weigh-in through those teams into the anchors. We have third sector representation, health and care representation. So there's a lot of people who are very interested in the recommendations. We're at the process now of thinking about how we continue to kind of deliver and maintain momentum around that, you know, after the publication of the report. But so that's, I guess, the first thing to say. What you've touched on with that question, I think, is around developing a health equity system. So I wrote the public health report. You might have noticed I put in there quite a few times a health equity system, embedding fairness in everything that we do and thinking about health as the ultimate aim of what we're trying to achieve. So I can genuinely say we're really getting there with some of the different departments in the local authority who will obviously be working towards those things anyway, but we're having such brilliant conversations with asset management and regeneration, for example, which Tim touched on before about, well, if you do build a pathway into, you know, big infrastructure work that makes it easier for people to go into the city centre, what are you actually doing to understand the needs of those populations and communities? What are the mechanisms that you're putting in place right at the start so that you're not widening health inequalities? So for those of you that know the recommendations well, recommendation 3 is my favourite one because that's about operationalising Marmot. So having lots of conversations with people on the delivery partnership about that. We're also doing lots of work to kind of distill and make simple what the Marmot work is so that we can go even broader and have conversations with businesses. We've got the Business Anchors Network, so there's lots of opportunities there, I think, in the future. And the Marmot team at the Institute of Health Equity have worked with Legal and General. Some of that money that's been freed up from Legal and General is coming, I think, into the Leeds system. There's certainly been a lot of bids that have gone in to Legal and General. So yeah, so there's lots and lots of opportunities there. So yeah, so I was going to say we're distilling and kind of communicating what the Marmot work is, and we're tailoring that to different parts of the system so that we can go slightly broader than people who are pretty much already there, committed to health equity and health inequalities, and start to say these are the 3 things that you can do within, you know, within, I don't know, the private sector. People have mentioned it today, and I love it when my words come back to me, but our unofficial mantra for the Marmot work is join up, scale up, and be bold. And the joining up bit is about what you see here today, but it's also about joining up across different ways of thinking and different businesses, understanding what works, and then scaling up to meet the needs. So I guess to sum up, what we're doing is we've really made really brilliant kind of strides forward in working with different parts of the council and different bits of the third sector that we may not have worked with before, but we really recognise that that's the next bit to do, is to go even wider. So Tim, I don't know if you were going to pick up on the...
Yeah, absolutely. Thanks. So not to add anything to that, but just to say the bit about multiple boundaries, I'm not going to pretend that I'm going to cracking it. All I would draw attention to is the fact that was one of the reflections and recommendations from the IHE. So recommendation 13 was about clarifying community approaches to addressing social determinants, including joining up the programmes and reducing duplication and scaling up what works. I think that touches to some degree on your point about some of those different boundaries and the community approaches. We're not going to pretend, and I'm not attempting to try and resolve that, but we are, I guess, shining a light on it through this and trying to draw attention to it, but also 2 things. One is a lot of work happening at the minute across all partners around the sort of evolving idea around neighbourhood community services, health services in a more integrated way, and we're trying to very much feed this into that process to shape and to steer that work as it happens, and hopefully that might be a mechanism to make a bit of sense of some of those boundaries we'll see, but also pragmatically working across those boundaries. So, you know, the structures that Sarah just talked about, we have people on there who work across those LCPs boundaries, you know, the care partnerships, but also the wards and some of those other boundaries, and really not being restricted or in any way confined in terms of building those partnerships out across those structures that work, including the education ones as well. But I don't know if health and care colleagues want to come in on the second.
Yes, I think Anna, did you want to come in?
Yes, thanks. I'm not sure we're going to be answering the questions in exactly the right order, but I'll come in on a couple of those pieces there. So firstly, the How Does It Feel For Me programme, yeah, use those videos quite a lot. I think I can identify the person you're actually talking about from those videos. I think, so within health and care at the moment, we know that everyone is making these kind of, let's face it, cuts, cost savings, quality value, efficiency, waste reduction. It's badged a different thing within every organisation, but that's what each organisation are doing. LCH actually have a pretty robust system, I'd say, in place at the moment, where they have got their kind of equality and quality impact assessments for these service changes that they're making through their quality and value programme, which is what they call their kind of efficiency measures. One of the things that we are really trying to get the services who are making these changes to do is exactly that. Think of these impacts on not only protected characteristics, but on deprived communities, different groups at risk, high risk of poor health outcomes around the city. I think sometimes when a service change happens, there's intended consequences and there's unintended consequences. So what we're really encouraging teams to do at the moment is use what we call this kind of quality and value dashboard for equity, and make sure that they've got some really key equity indicators embedded within their dashboards, so that when they make these service changes, some of them will be much bigger, some of them will be a bit smaller, but they're actually keeping an eye on those intended and unintended consequences on equity, and then they're reviewing those as part of their kind of equity impact process. Because I think sometimes, even if you do a really good equalities impact assessment, there's going to be stuff that you miss. There's going to be that consequence that nobody foresaw, you know, that there was another service that was cut exactly the same time, and that communication was missed or whatever. So I think it is really important that those impacts are kind of monitored going forwards, and that there's feedback, whether that's the quantitative numbers that are changing, or like you say, these kind of qualitative patient experiences that are actually saying, hang on, we might not have got the service change quite right. So that's what we're really encouraging those colleagues to do at the moment. I was going to touch on the mental health question too, but I might go to Nick first, and I can always add if I need to add anything in there.
Great, and thank you for your questions. I've tried to take note of them, and I will try and answer them in order, but I'm happy to take further questions. So on the Healthy Leeds Plan priorities and mental health, and looking at crisis episodes, that was noted in the original discussion a year and a half ago as a known weakness of that approach. One of the reasons was two connected reasons. One about how data flows in that area in particular. Two is about connecting the reason for attendance to the driver of attendance, which for mental health concerns gets particularly difficult. And to try and balance that, we took an active view of making sure that mental health not only appears, so it does appear in the priority areas for Goal 1, in two of them, so our community mental health transformation and long-term conditions and SMI. So we've not lost focus on the needs of that group by the weaknesses in the process. But the other bit I'd point to is that since obtaining the data and being able to do a bit more around it and work with that data for Goal 2, actually mental health is one of the two priorities associated with Goal 2. We just haven't distilled it to a set of this is what we need to do in that space. But we've now got the information that allows us to start to do that. So I think I'm noting and acknowledging the omission, and I think we've got a route to try and correct that omission. On the quality impact assessments in the ICB being a new process, I just qualify there, they were always an existing process for any public sector organisation. What was new in the ICB was partly that we were a new organisation, so we had to recognise that this was, maybe it's the first time doing it as an ICB rather than as a CCG. Recognise the point around doing it openly. We actually publish our quality and equality impact assessments online now, so you can access them directly on our website, and I think that's part of that commitment to doing so as transparently as we possibly can. That doesn't quite answer your partnership point, and I think that's probably a next step for us as a partnership. And then the last thing, it's been touched on by partners, but I guess just a thank you. I sit on the ICB subcommittees this month, all three of them, and those stories that we hear from or through Healthwatch of people in Leeds really set the tone. They're sometimes quite hard to hear, but they really change the nature of the discussions when you're having talks around strategic challenges and strategic decisions, to be grounded in actually what does it mean for me. So yeah, I won't comment on a specific individual case, but just to acknowledge that I have seen that, and it does change the nature of the discussions we have, and thank you, and please keep bringing them to us. Really appreciate it.
Thank you, Chair. I'd just like to add a brief comment to Jane, your question about the community boundaries question. I think it's really interesting and pretty fundamental, actually, because anyone who's been around the city for a long time knows that there's been conversations over decades of trying to line up, school clusters with NHS neighbourhood teams and all of the rest, community committees, how that fits in with electoral wards, etc. Without any resolution on that. And I think that now we're in an even more challenging situation where we've got academies in education that, obviously this landscape's getting more complicated, isn't it? But for me, I think it's really important to almost turn that on its head and say that's the wrong question. The wrong question is how do we make everything fit with everybody's organisations? The right question feels to be, how do we develop models of working based and centred on communities that serve the needs of the people in the communities? And if we organise ourselves in different ways, that's our problem to sort. And actually that shouldn't come into the barrier for why we're serving the communities we serve. So I do think we've just got to get over that reason for not doing things, if that's been a reason in the past, as well as we should have done. And I guess the real challenge, it's been mentioned in the presentation so far, is that despite good intention, we've seen more of our activity across health and care move away from communities and centralise over the last 5 and 10 years. The opportunities, going back to Councillor Gibson's point about new government, the opportunities around the focus on neighbourhood health services, I think give us a new opportunity to say, how do we do this better and actually really centre our attention on putting communities and people at the centre of this, and we'll just have to make that work with our different boundaries. So I do think there's an opportunity there, but I think we have to move on from trying to make that jigsaw fit together, because it's kind of the wrong question. Thank you.
Yeah, thanks for that. That's really interesting comment. I think certainly I guess the only challenge back to that is making sure you have services in each of the communities, and how you map that out is but that's a practical question for the establishment, is what you're saying. So I think that's really helpful. Thank you, Victoria. Okay, I'm going to bring in Councillor Buckley next.
Yes, thanks for this. On the report, Scaling Up Good Practice, we've just been talking about mental health and temporary accommodation, and you say, we're proactive to opening cases at the earliest time to help to prevent homelessness. Well, what happens, for example, if somebody is mentally incapable of communicating properly with the team, filling forms in, and applying for temporary accommodation? What happens how do you prevent them from slipping through the net, which I'm sure people do? do organisations keep a close eye on these people when they first come to apply for housing? Because sometimes they just cannot communicate, continue communicating. Is anything in place for that?
Thank you, Councillor Buckley. You know, it's a really good question, isn't it? And from my third sector perspective, it's one of the examples of where having a breadth of provision and having community organisations that know people and are linked in and are available. So, for example, I know Rainbow Junction, one of the places in the city that provides food and a lot of support and information on housing and mental health. It's like a real community hub grown out of a church just up the hill in just up in Woodhouse. You know, is a really good example of where having that relationship and that connection and having people that can work in those different ways can really help kind of bridge those things, because I think that's where we need a city that stitches together the different pieces of the jigsaw that we need across that provision. I think another example is around some of the mental health transformation. We're doing some really powerful and innovative work trying to develop different ways of working, including giving greater access around information and support through community hubs. We've got 3 hubs that have now gone live across the city, because we know often there's a strong link between mental health and homelessness. So that's one of the examples where having a distributed, dispersed provision, which may be, just to pick up on your point, Councillor Stokes, it perhaps isn't always a case of having every service in every community, but it's making sure that there's access and that there's no wrong door, really, that the people are able to make a link through, and that, you know, we're not sort of turning people away or saying, well, you can't have that because you live in this bit of the city, but we're making sure that things are fitting together as well as they can.
Thank you. Okay, Tim, do you want to come in next?
Yeah, just briefly, and I just have to start this, Councillor Buckley, by saying, I mean, it's not my area, particularly working on the homeless or the housing. What I would say is one of the findings of IHE when they came in and looked, because housing's been one of our focus areas, is actually the very low rates that we have of temporary housing in Leeds, and they saw that as a huge strength. And I've just found the housing data pack, that's one of the documents that they've put up on the IHE site, and it does say Leeds in its temporary housing approach, Leeds has maintained very low numbers of temporary accommodation, particularly when compared to other core cities and have comparable homeless duties. Leeds keep temporary accommodation placements as short-term as possible by providing support to those in provision, by assisting households to bid for social housing, applying for benefits and maximising income, searching for private rented property and arranging viewings. And they go on to talk. So, as I say, I can't say in detail, but certainly that was one of the findings that IHE found, was that we had these incredibly low levels, although they did notice they were starting to creep up. But I think that was indicative that there is quite a lot of good support in Leeds that happens at that very front end around some of that homeless work and temporary accommodation.
Thank you very much for that. Okay, I'm going to bring in Councillor Runtree next.
Thank you, Chair. I've got 3 things here I'd like to ask, if I may. To some extent, I think the first one was foreshadowed by Jane's first question, but I'll put it anyway, see if there's anything specific that people might like to offer there. I think it's sort of clear from your presentations today and the reports that have been circulated that there's a danger on relying too much on average for the city. And as an average, the level of affluence for Leeds is currently pretty close to the national average, I believe, and to the UK median. But the much larger share of our population, and especially children in more deprived deciles, shows that average can sort of actually obscure a lot of what's going on. I'm just wondering if we're aware of over-representation of lower levels of affluence and of deprivation among young people. Does that mean that we've got, to some extent, baked in a trend that's working against us of increasing inequality that's going to put more pressure on us in the years ahead, unless we can address the non-health side of this equation, the economy, education and skills. I'm wondering what public health professionals and medics can offer as asks to these non-health sectors, if you like, to achieve progress. What kind of things you might be able to ask them to do differently. Another thing that came out to me was, whilst we got a sort of very sort of vital and lively engagement going on with the public sector and third sector organisations, it's not clear to me if sort of the private sector and the world of business are equally on board of this. And I know in the reports there's a mention of Leeds Business Anchors Network, which it's in the report, it doesn't seem to have an equally high profile with some of the other forums that have been mentioned. I wonder if that's fair, and if if that's fair, and if that's something that you think could be changed. And my last question is not quite a concise one, I suppose. Thinking about individual behaviours, I guess it's fair to say that the sort of the traditional public health advice on things like smoking, drinking, diet and exercise, it's easier to deliver to more affluent communities. And I'm just wondering what we already know about how to deliver these messages effectively in more deprived communities without descending into finger wagging. Thank you.
Yes, so thank you for the question. I think you're right in what you were saying about are we baking in problems and issues for the future, given the high proportion of children that live in the most deprived parts of the city. So I think on Tim's slide it was around 33%. So those children are going to get older. Obviously, what we can do initially to prevent that is all within the gift that we talked about in terms of the marmot work, in terms of improving the conditions and the lives of parents, all the work around kind of inclusive growth, economic development, improving housing. So before these children are even born, really, really important to support people preconception, before they're even thinking about children. One of the priorities in the marmot work for the last year or 18 months has been around 0 to 5s. So really, really important that we design the world so that everyone has an equal opportunity to be healthy. That's kind of the baseline of this work. But then once these children are born, and if they're born into the most deprived parts of the city, then huge amounts of work that needs to go in to support them. And I think the data pack is on the website from the IHE work on 0 to 5s, and there's lots and lots of information there about differential outcomes around things like educational attainment that you can see are different very, very early on in a child's life. So there's work ongoing through the marmot work to address that, but there's a huge programme of work which I won't go into in huge amounts of detail, but through the Children and Families Public Health team to kind of really support and mitigate some of the risk that is having an impact on those children's lives. And that's particularly delivered through the 0 to 19 service, which, as Victoria said before, everything we do in public health is focused on health inequality. So the 0 to 9 service has kind of 3 different parts to it, universal, targeted, and the third one, which I think is something specialist, pathways, intensive. So 3 different levels of support for children. So, yes, so lots of work to give everyone an equal chance. Yes, potentially if we don't try and turn the tide on that somehow, and that's within the gift of us in the marmot programme in public health in Leeds, but also nationally, we need to develop better policies so parents and families aren't up against it before they start. But huge amounts of work already going on in the city already. Did you want to?
Yeah, thanks. So I won't say anything further about that. I think Sarah's covered that. Just on the private sector question, yeah, I think it's very, very much a work in progress. So the and this is where we work very, very much with other sort of partners, so particularly inclusive growth, one obvious area. They do have the lead around the inclusive anchor network, so that includes some aspects of business, but mainly the sort of broader public sector ones. But they have now launched this business anchor network. So again, we're working very closely with them about what that looks like and getting those, understanding the impact and I suppose the opportunities around health. I think it's slowly moving, but also just the inclusive growth strategy full stop, about what a mechanism that can be, about the message that we send out to business in the city about how we want people to work and contribute and support as part of it. Pip mentioned about social value and the opportunities there as well. So I think we are doing it, but there's still further to go. Other examples, nationally, IHE, the Institute of Health Equity, which is the Michael Marmot organisation, if you like, they've got a very strong partnership with Legal & General, so that's something that we've linked in a bit with. Obviously, we've talked about the grants that they are offering, but we also engaged, and I was part of an event where we were working with some certain private sector businesses down at the PwC buildings, looking at the safe sick pay issues, really challenging in the private sector in some of those very real areas around sort of property and property management, where big workforces, but really challenging terms and conditions that are really impacting people in terms of those sort of broader determinants. So we are definitely sort of seizing those opportunities. Another opportunity that's again come up that we're looking at developing through the Marmot work is large housing developers, which are interested, again off the back of the Legal & General work, and at a national level, being part of that programme is giving us a way in because of the status and profile that Leeds has got with that work. IHE are then coming to Leeds saying, we've got these sectors wanting to work, would you be able to do something with them? So there are definitely areas that we're working on, but I think it's trying to, in some respects, get our own house in order as well across areas of the public sector before going out to do that further. Just a couple of points on your last question, which was about the individual behaviours. Yes, I mean, ultimately, how people behave, people's individual behaviours impact their health, but we know that the reasons and way people choose those behaviours aren't all equal, and the fact we see that social gradient through every behaviour, we understand fairly well that what influences people's behaviours are a vast range of things. So I think the sort of headlines, I suppose, for me about what we've learnt about what works well are understanding and trying to do our best to understand, appreciate and recognise, and then help address what those causes of those behaviours are, what those influences of those behaviours are, what some of the barriers for people making those healthier choices that they might want to do, whether that's about eating, whether that's about the way in which they travel, whether that's about understanding the circumstances people are operating under, the stress and anxiety that causes and influences people's decisions and behaviours, and having that real understanding about those barriers and building that into programmes and that we're trying to do to address it, and critically working with communities and people themselves to help understand that, and that sort of broad range of partners, very much including third sector. But I think Anna wants to come in there as well.
Thank you. I'm going to bring in Nick, then Victoria, then Anna.
Really quick, but great question about the private sector. You started by saying the non-health side of the equation. I would change that to the non-health provision side of the equation, because actually LTHT employs 25,000 people, and they will have a huge impact in their employment practices on deprivation, working mothers, sickness, training, education, all those aspects. So we have a role in that space as well, but I think we could do more on the private sector side.
Thank you, Chair. Firstly, just to your comment, Councillor, around the whole of Leeds kind of data is the least important and the least interesting to us. I just wanted to acknowledge that and agree with it. It is the least interesting cut of the data. What is really the most interesting is this difference across the city because of the nature of our population. So just to pick that up to agree with that comment. And then just very briefly on question 3 about that, how do we deliver really impactful public health with local people when we have such a challenge around health inequality? And building on what Tim said, there's kind of 3 things I just want to mention in addition to that. One of the Marmot recommendations is to kind of work with people around prevention and their health and well-being in a way that takes into account the lives that they live. And that's a really simple thing to say, but actually when we talk with our frontline workers, lots of frontline workers feel really unconfident in doing that, particularly if people are living in great poverty, which we know a third of our children and a quarter of our adults are. So there's a whole piece around how we do prevention work which is compassionate and understands the real lives that people live and isn't coming from a sort of a middle class sort of finger wagging point of view, which doesn't understand the realities of people's lives. So there's a major push, and which is part of the Marmot approach as how we take that forward. The second kind of key bit of the jigsaw is how we continue to work with trusted local organisations and communities, including our third sector colleagues. This was probably the most significant learning from COVID around kind of don't go out there and do to communities work with. And one of the things that really impressed the Chief Medical Officer when he came to Leeds was how much we still value, of course we'd always like to do more, but how much we still value that bit of the jigsaw in trusted local organisations being an absolutely critical part of that solution. So we need to do everything we can to make sure they are part of our infrastructure, picking up on the points that Pip's made. And then thirdly, the whole thing about creating the conditions for it to be easy to people to be healthy is where the major evidence is for what makes the most difference. So we know from the conversation we had about healthy weight here at Scrutiny Board around actually what really is least impactful are individual interventions when people are overweight or living with obesity. What actually makes the most difference is looking at the environment people live in and how we can really address that by working in different ways. So there's work around licensing. We know that people in poorer communities have more fast food outlets, less access to healthy food than people in more affluent neighbourhoods, for example. And also, you know, that does involve working with businesses, kind of in a kind of a policy way as well. So the whole tobacco and vapes bill that's coming through Parliament is really looking at, you know, the tobacco industry and the harm that does to communities and how we can support people, even if they're smokers, to be as healthy as they can. And therefore it's not victim blaming, it's actually looking at the big drivers of what makes people suffer poor health. So I would say that there's been quite a radical shift in kind of old-fashioned sort of behaviour change interventions to something that really understands why we are where we are and actually takes that blame away from individual people but really looks to support them in the ways I've just described. I hope that's helpful. Thank you.
I'm not sure I particularly need to, apart from just to emphasise Victoria's point there where she was saying, I think this whole complexity of working with the private sector, we know that obviously there are some kind of private sector organisations who want to embrace this topic, that want to embrace the topic of health inequalities. But we also know that there's some kind of private sector organisations who are almost actively working against us in this space. So, you know, Victoria's just highlighted there, tobacco industry, food industry, alcohol industry, etc., kind of actively working against us in these areas as well. So it's that complexity of working with the private sector and trying to bring along anybody who wants to come on that journey with us. But yeah, recognising we're not all trying to get to the same goal actually as well.
Yeah, thanks for that. And I think that's really astute observation. I've brought up before, I've been on the bus home before and seen sort of friendly adverts for what appears to be a health product, strawberry flavoured health product, but it's a strawberry flavoured vape aimed at people under 16, in my opinion. And that's a real problem. Just the other thing in terms of the 1/3, I think the thing that we haven't talked about is, or wasn't mentioned, was education. I think that's real. I know it's on the graph that Tim had on his slide. That's real opportunity for young people. Councillor Wanchi, did you have any follow-ups?
Just one thing, please. And are we confident that the way we've defined an inclusive anchor network as distinct from a business anchors, that's the right approach? That I'm starting to think from what you've been what's been said in response to the questions that it probably is. But is there anything you'd like to put into that? Thank you.
Yeah, I mean, it's as I say, other colleagues that lead it, and there's colleagues sat here from a range of those anchor organisations. But I think it does make a lot of sense, and Leeds, I think, is quite well recognised as having a very quite advanced approach around its anchor network, I think, and gets quite a lot of recognition. But the inclusive anchors does include the likes of the key health trusts and providers. It includes the universities, the council, and also some of the large utilities as well. So that they're the sort of organisations that have traditionally been part of Anchor Network, and then really expanding that approach out. So there's been the local community anchor network then, which is developed as a legacy out of COVID and very much in the third sector, and recognising the alignment of that anchor network alongside it, and then trying to take some of that into that very much that private sector world. And as I say, they developed the business anchors as a starting point that got launched at the same time as the inclusive growth strategy last year, I think. So yeah, it does feel hopefully quite good.
Thank you, Chair.
Thank you very much. And I think there's also a good case that we need to keep making to the world out there that there's good reasons to health benefits help you in the long run as well for like private sector companies. Okay, I'm going to bring in Councillor Bromley next.
Thank you, Chair. It's hard to think that there's still a question left after all of that, isn't it? A few things have already been touched on, but I just wanted to ask something actually more specifically, and it does fall into third sector. So in terms of on a local place from Horsforth, we have Leeds Climate Action that have done work with the communities in terms of how do you really engage with people that may not necessarily normally get involved with projects or even have the time to be able to, and how do you actually create it so it's even supporting the community. And so much always comes back to, if you address something that's an economic difficulty for people, something that they can't normally access, their mental health and isolation, then you have a successful project. And one of the things with the repair cafes, then it became one of the most well-attended projects because it actually put something in the community that was completely missing for people. So I wonder then on a larger scale if we can connect this up in terms of Leeds Climate Action have brought to our Climate Emergency Advisory Board, how they'll now be looking at moving forward and addressing, especially in communities of diversity where the engagement is also still in their admittance still missing, and how they look at then creating that rapport more and taking responsibility with that. So I think the work aligns really similar to this, and also then allows that level of human contact and a local community level with the work as well. Thank you.
Yeah, no, thank you very much, Councillor, for raising that. I mean, it's a really interesting area, isn't it? And I think that link that we see between, we haven't touched on all of the issues around parks and green spaces and all of the things that kind of, other things that kind of add. And we've got the Green Active Providers Network in Leeds, which I know is linked in. And Meg might want to come in to talk about the climate action work, because that's an important kind of area too. I suppose it's that kind of finding things that resonate for people and ways that connect people. I think that's one of the real sort of strengths we have as a city, is that ability to kind of find ways that people can have a role. We know that so much of what matters, we've touched on mental health earlier, is around people having a sense of belonging and community and purpose and things to do. In the same way that you might eat your 5 veg and fruit a day, there are things that you can do that contribute to your health and well-being, which in turn have that kind of community network. And I think the same is true, you know, going back to the question around business. I think we've again got some good networks like the Mindful Employers Network and kind of other ways in which actually I think one of the things, Meg and I were in a meeting yesterday where our colleague from Leeds Community Foundation, who works with philanthropy and local business to try and think how do we get people to invest, you know, in money, financial terms, as well as kind of what organisations can do in terms of social value. And I think there's a sense that looking after your workforce is a really important part of that, and connecting with local community and businesses. So I think a lot of these things, there are so many threads on there. So much of this is, you know, it's a complicated system that we're trying to work in, but all of those different ways that we can join and connect and help people find routes in, I think is really important, isn't it? Because that will be different for so many different people. But yeah, climate is a massive issue, and really good to see the council, from my perspective, doing so much around active travel and thinking about how we make that safe, because again, it's helping people have those ways in which they can make the positive choices, and that to be as easy as possible, so that we're sort of set up as a community in that way.
Thank you. Meg, did you want to come in as well?
Yeah, I suppose just kind of reflecting on your question and how it was similar to around that, almost around that behaviour change question really, and reflecting also on what some colleagues have said about really listening to and understanding why communities have certain behaviours or do certain things. And I think one of the reasons why repair cafes have worked so well is because it's what people want. They're like, it saves them money, it's like a new skill to learn, it's a social thing, like it's not something that's being put on them. So I think, yeah, there's that real value in the third sector, knowing communities quite often, or at least having that reach into them to be able to kind of speak to them on a personal level and understand, and just listen to them really and understand where things have come from. Just kind of relating to climate action, found it really interesting. A colleague had, at Climate Action Leeds had done some engagement with some groups of young people, culturally diverse young people in Chapeltown, and had been asking around like, oh, what's your perception of like climate change, and like why is that important? And the things that they were coming out with were so different to what we would hear in places like perhaps Horsforth. They were really concerned about 5G towers, microplastics impacted on young girls getting their periods earlier. Like the perceptions that different communities have are so different, and I think, yeah, you're totally right in that kind of identifying the repair cafe as an example of where that's a real community want, like that's something that they have a real desire around. And I think there are opportunities around health as well, where actually people really want like community gyms and stuff like that, and that there's opportunities there to kind of work with what people already want and can tell us.
Thank you very much. And I think there's something around the social aspect being really important for people and the wider health benefits. I can't quite tell if you're indicating, Tim.
Yeah, well, it was just very briefly, and just really to say, yeah, thanks for the thought and the idea, because I have to say there's 8 Marmot principles, which are sort of fairly well known, best start in life, etc., and they added 2 more into that. Well, there was 6 originally, they added 2 more in over the COVID, and one of those was pursuing environmental sustainability and health equity together. And if I have to say, there's probably one area of those we've done least on and probably made least progress and done least thinking about is probably that one, quite honestly. So I think that's really good thought and inspiration, and that idea, because we do have a really strong principle about community engagement and community power linked through all of the Marmot work. So actually thinking about where there might be some synergies and opportunities to build with some of those sorts of organisations, like you mentioned about the Leeds Climate Action, is it's a nice idea.
Do you want a supplementary, Emmy? Yep, Kemp's up.
Well, actually, it's more of a comment. Is that okay? So just to thank you for that and information and feeding back on your conversations with them as well. In terms of on our board, we're also looking at a subgroup for bringing Leeds Climate Action into the education and bringing Helen Hayden into the conversation regarding how we might do that across Leeds. So then maybe that's something then that could tie together, because then you're looking at diverse groups, bringing in that education and how you link it in with health at the same time. Just a thought again.
Thanks for that. Take that as a comment, but that's very helpful. Thank you. Okay, and then the last person on my list is Councillor Ritchie. Thank you.
Thank you, Chair, and thank you for the presentations. And there's no denying that everybody in this room has got a real commitment to reducing health inequalities and improving equity, which is really good to see. And it's good to hear that the government are committed again to the crucial things like Marmot that we've embraced in Leeds. And it's really important that they deliver, because I cannot, and I'm sure I'm not the only one who's not proud to see a graph or a picture up there of the city with so much red on it, which is probably very similar to when I were elected in 2014. So that's 10 years of missed opportunity. So as I say, I hope the government and the Better Had do address these matters with appropriate funding. Just one other thing I want to pick up on. In terms of equality and equity, that's came through really strongly through the council. I know John Ebo's done a lot of work around that with our EDI team, and it's really important to see that. I saw less of it in the NHS presentations. However, to be fair, Anna did refer to it quite strong. Is Anna, isn't it? Yeah. Strongly, which I'm pleased to hear about, and just was seeking that reassurance that that is embedded in the NHS equity as well as reducing inequalities. But what I really want to focus on are the health checks. When we think back again to the slides on the building blocks and all the different things that are brought in, I just wondered, so I'm referring, we're on page 28, 17.2, the NHS health checks. I'm aware of an over 50s health check. There's an annual learning disability health check. Are there any other specific health checks that it's referred to about these that are targeting health inclusion groups, for example? Because I think there's an opportunity to perhaps review what's involved in those health checks, where they're done. So, for example, people are coming to A&E rather than GP, so primary care. Could they be done when they're at A&E? You know, is that perhaps a GP service within A&E? There may already be, but that sort of thing. Are the questions asked relevant? So to link in, I know the over 50s health check is quite limited, so it won't link into mental health from memory and transport and housing and so on and so forth. There just probably isn't the time. But also crucially, what is the follow-up from those outcomes? So that's the sort of thing, perhaps reviewing those NHS health checks, because I imagine they are a crucial role because it ties into everything that follows. Sexual health, you could ask around that. The other things, drugs, alcohol, so on. I know they do ask about alcohol, I recall, smoking, and mental health generally. So that's the kind of question about those health checks. Are they relevant? Do we follow up from them, and can we make them more productive? Thank you.
Yes, as a colleague was just saying, it's my specialist subject. It's one of the areas that falls under me is NHS health checks. Yeah, great question. Thanks, Councillor Ritchie. So yeah, I think there's sort of two sides to that. One is a really good story. It's almost like I could have lined you up to ask that question. We have a great story to tell about NHS health checks in Leeds. We have one of the highest rates of both checks that are offered, but also the uptake of rates. So we have a really high rate of coverage of our NHS health checks. But what is more pleasing than that is that, as Victoria was saying, all of our services we we do target a sort of proportionally to areas where they're most needed. So we weight our payment structure for the NHS health checks to incentivise undertaking checks in those that we do, the sort of categories of those that are most likely to benefit from them. And what's just fantastic is that we get, not only do we get such high rates overall, but I think we get just over 50% of those checks are done in those groups that are most likely to benefit from them, which just feels like a real vindication of the approach that we take, the investment that we put in, but the approach that we take and the way that the contracts are structured and that we work with the providers to be able to do that. So that feels really a good story. The other thing that we've done is because those health checks obviously didn't happen through COVID, there was a real backlog and a lot of people didn't happen. I think credit to Leeds, we've managed to protect some of that resource, use that resource to do the catch-up activity. So where we've got providers that are already hitting the sort of ceiling of what they've been able to do at the moment, we've been able to extend that ceiling and say, just keep doing more of what you're doing. So that's been brilliant, particularly where they're hitting those most disadvantaged groups. But we've also been able to provide an additional contract to trial new and different models of health checks, which are working with community providers. So that's explicitly about going out and this was very much pushed and was very much supported by Councillor Arif when she was a portfolio holder in this area. To work with community organisations in those areas most affected to try and think about exactly that. How can we get out and reach people that wouldn't otherwise turn up for the health checks? How can we hold them in places outside of GP practices? How can we work with those trusted organisations in the community to try and reach people that aren't currently being reached by them? So that's, I think, a really positive and a good story. And I think there's equally good work happening around the learning disabilities health checks that happen. As you acknowledge, though, that the NHS health check is a nationally mandated check and is limited in terms of the breadth of things that happen. So it isn't, we're not able to completely tailor that check around people's individual needs. We can, though, put quite a bit of work in, and we do try and put work into the so what. People getting a health check is one thing, but that isn't really what achieves. The achievement of it is what the quality of that interaction's like with the person at the time, and what happens as a result of it in terms of any follow-up that happens then in terms of pathways they end up on, and what follows up in terms of any change in behaviour that they undertake as a result of having done that. So we really do try and put that emphasis on the so what about them too. One thing which I'll just also mention, though, is it's not strictly a health check, but it is listed in the paper that one of the examples of good practice that's happened in Leeds, and part of being sort of inspired through all the inequalities work and people taking that on and the sort of spirit of the Marmot work and things, is one of the GPs in Leeds that's developed a particular template around the social determinants. So they've grown that and developed it themselves. They've worked with colleagues within public health who supported to do it, and we've linked in with other colleagues across the system. And it's an absolutely fantastic template that they're now rolling out across primary care in Leeds, and it enables when people come in to a practice and have a conversation, it gives a very easy tick box way of capturing the different social determinants that are talked about in terms of any employment issues and transport issues, housing issues and the likes. So firstly, they're now recorded on the system in a way, because at the moment there is no way of capturing, of looking across the GP primary care systems and understanding the extent and regularity with which people come in. So it would give a way of recording that. But critically, it also holds all the referral data within that template as well. So it's a bit like the repair things. It's giving GPs what they want as well. It's not just asking them to do work. It's giving them what they want, because it's putting all the information about the up-to-date referral networks, whether that's about employment skills, whether it's about welfare advice, whether it's about housing advice, whether it's about third sector links, all in one place. So it hopefully really serves is a bit of a win-win. So that should go, hopefully, start to be some way in terms of moving towards that sort of more tailored, rounded approach when people do come into contact, where they can then be more opportunistically addressed around some of those wider issues.
Thanks for the question, and I just wanted to just build on what Tim was saying there. in terms of the kind of A&E piece that you kind of suggested, why aren't we getting people in A&E and whatever, I just wanted to tell you about a bit of a scheme that is going on at the moment in A&E, because I think it is very similar, but it's a slightly different tactic. So it's not necessarily a health check, but we've had a lot of conversation today about how there's so many other factors that impact health beyond just the health and care services. And we recognise that so many people who attend A&E are actually coming in with potentially non-health issues, or they might have a health issue, but there's a kind of a broader complexity around that. So at the moment, in A&E at the Acute Trust, they have a wellbeing coordinator. So some people call that social prescriber, wellbeing coordinator, but basically somebody who's going to talk to people, examine what their kind of health goals are, and try and link them better into kind of either community activities, other services, to try and meet that kind of broader health needs. So like exactly what you're saying, why aren't we expanding that health check to think a bit more broadly? This is kind of a similar approach, basically, to kind of take that slightly more holistic view of a person's needs when they're coming into A&E. So hopefully we'll get some good data from that kind of trial, essentially, and maybe start thinking about how we can scale up some of this approach more broadly. So thanks for the question.
Super, thank you very much. So I've got to the end of the questioners. I don't know if Victoria, you want to say anything in closing, but I'll just give you a moment to think about that. So my thoughts are, there's been really positive conversation. I feel like there's a real commitment from everyone around the table to this agenda, and so I'm really, really pleased about that. Hopefully you've heard that there's real support from the scrutiny board on this. I think it's clear that we're supportive of that. And so we very much hope that there's continued investment and focus on this. I'm not sure yet when you'll come back, but I'm sure we'll want you back at some point and want to see progress in terms of closing that or reducing the number of people in that bottom decile nationally. And I think that has got to be a focus. Having put you on the spot, do you want to say anything closing?
Thank you, Councillor Scopes. Well, just to say thank you all for the conversation this afternoon and the quality of the conversation, which has felt very good and very constructive and supportive. So there's lots for us to take away there, which we will do on all of those points. I think there is something about keeping the momentum on this conversation. We've had the good part of an afternoon on it, and it is incredibly complex, and we'll go away and continue to work on this agenda. But I think there is something about having a think about when we want to bring this back and what we want to focus on when we do. And then I guess in the meantime, knowing that we bring a performance report every 6 months, which is broken down as much as we possibly can do around inequality. So I think there is something about continue through that performance report conversation, just keeping an eye on, some of the trends and some of the headlines from those reports, because, that is all part of this conversation about how we're doing. So thank you, lots for us to take away, and we'll look forward to bringing this back again. Thank you.
Thank you very much. Okay, so I'm going to close that item. So those at the end of the table, you're free to go. It's a public meeting, so you can stay and listen to our work schedule conversation if you're keen. I don't imagine it'll take too long. So just moving on to item 8, the work schedule. Just a couple of things to note, that we've got 2 working groups set up in the diary. Hopefully you've had invites, one on the 25th of November about adults and children's neurodiversity assessments, and the other one at a budget consultation on the 19th of December. Hopefully you've seen the work item in the pack. Are there any questions from any members about the item on the schedule? Is there anything you want to say, Angela?
Nothing specific. I guess the item itself is the summary note, so it is there for members to note and just formally ratify. So happy to take any further comment on that as well.
So unless anyone has any comments, I'll take that as agreed. Good. Okay. So with that, I'll close the meeting. Thank you everyone for your time. As ever, do feel free to get in touch in between meetings if there's anything you want to raise. Have a nice evening. Take care. Bye.